Good afternoon, everybody. Welcome to the final Humanities Forum of the 2023-2024 year. Delighted you all could make it on this beautiful afternoon. My name is Ian Bernhoft. I direct the Humanities Forum, and in a minute I'm going to give this microphone over to people who have more interesting things to say than I do, but I want to introduce the forum and give you a quick snapshot of what to expect over the next 75-ish minutes. So, first of all, the Humanities Forum is an initiative of the Humanities Program, and it's an opportunity for Providence College to come together outside of the classroom to deepen our shared intellectual life, to hear from scholars and journalists and practitioners from around the world, to explore diverse perspectives, and to deepen our appreciation for the humanities. Now, any given year, the forum, we have a number of different partnerships with different departments, different initiatives on campus, and one of our most valued ones is with the School of Nursing and Health Sciences. This is the, I think, third, maybe more. We've collaborated on a number of talks this semester, and this one is co-sponsored by the SNHS, and also is made possible by a grant from the Feinstein Institute for Public Service. Now, what you should know is that, first of all, we'll hear from our guest. We'll speak for 45, 50 minutes, something like that. There will be Q&A after that, and our long-standing and unalterable tradition is that a student has to ask the first question. So as you listen, you have those wheels turning. Don't just passively absorb, but actively, critically think, what do I want to know more about? What do I want to press our guest on? What kind of insight am I hoping to gain further? But when you ask your question, I'm sure it's going to be a great question, make sure that you wait for the microphone to get there so that everybody, including future generations on YouTube, can hear your voice. We're going to wrap up fairly promptly around 4:45, and right afterwards there's a really nice reception just down the hall in the Fiandella Great Room. We hope you can join us there and continue to have the conversation. Now, the last thing I would urge you to do, I know it's hard, but I would strongly encourage you to close down those shiny screens so that you can actually be present to what's happening in the room and not distracting yourself or your neighbors. Mandating. I'm mandating it. Yeah, I'm not your professor, but I can shoot you glares with the best of them. Anyway, I want to now hand this microphone over, as I promised, to Professor Amy Delaney, who's an assistant professor of nursing at Providence College. She's going to introduce you to our special guest.
Good afternoon, everybody. Nice full house, so thank you for coming to hear Dr. Jim O'Connell, who I'll be introducing. I want to thank Father Sicard, and Ann Molek is here as well, and Dean McInnes. Also, the Feinstein Institute for Public Service, who actually grant-funded a community initiative with us. So every first-year nursing student this year, as part of the Intro to Professional Nursing course, read Rough Sleepers as part of our social disparities and health delivery module units. So it is my honor, Dr. O'Connell, thank you so much for coming. I'm a pediatric nurse practitioner as well, and have had the honor of hearing Dr. O'Connell speak and following his work for many years. So Dr. O'Connell is currently the president for Boston Healthcare for the Homeless program, and he is an assistant professor of medicine at Harvard Med School. He graduated from the University of Notre Dame a few years ago, and has a master's degree in theology from Cambridge University following that. And after graduating from Harvard Med School in 1982, he completed a residency in internal medicine at MGH at Mass General Hospital. And shortly after that, in 1985, his life took a turn from reading the book that he didn't quite expect, where he began full-time clinical work with homeless individuals as the founding physician of Boston Healthcare for the Homeless, which now today serves over 10,000 homeless individuals and families each year in 2 hospital-based clinics, Boston Medical Center and MGH, and in over 30 shelters and outreach sites and on the streets of Boston. This innovative program now provides acute, subacute, pre- and post-operative, and palliative care in freestanding Barbara McInnes House, which is 104 beds currently. He is renowned. He has served as the National Program Director of the Homeless Families Program of the Robert Wood Johnson Foundation and the U.S. Department of Housing and Urban Development from 1989 to 1996. His articles have been widely cited and have appeared in the New England Journal of Medicine, the Journal of American Medical Association, Circulation, and the American Journal of Public Health, to name a few. He has received numerous honorary degrees and awards, and he has collaborated with homeless programs in many cities in the USA and across the globe, including Los Angeles, London, and Sydney. In 2023, Dr. O'Connell's work was chronicled by the Pulitzer Prize-winning author Tracy Kidder in Rough Sleepers, Dr. Jim O'Connell's urgent mission to bring healing to homeless people. So we welcome Dr. O'Connell to Providence College. He's a Rhode Island native person, so he is happy to be here, and we thank you for coming and joining us.
Thanks for not saying the year. Thank you very much, Amy, and thank you for not saying the year, although several of you here who know the year that I graduated. But I am a Rhode Islander, by the way. I grew up listening to Providence College basketball. Still listen to Providence College basketball, but it was my passion. That's what I want to do with my life, but just wasn't quite good enough when I got to that time. But thank you very much to Father Sicard for being here. I'm quite honored. And I'm realizing that your dean has a very sainted name in our life, Dean McGinnis. So I will tell you some about McGinnis here. And then I also, one of my classmates from Notre Dame is Dr. Lima is here, Hugh Lina, who I can tell you lots of stories about if anybody wants to come have a beer with me afterwards. But the worst part of the story is I was madly, passionately in love with this beautiful woman at Notre Dame. She went to St. Mary's, who has been Mrs. Hulina for the last 45 years. So to that, I say thank you very much. 50, I'm sorry, I'm dating. I didn't want to go too far there, okay? And then I'm very, when you hit these nostalgia things, and I'm sorry about this, you guys, but it's Rhode Island. I come back, and here you are. But Lynn Batchelor and I used to work together when we were teenagers at the LaForge in Newport, Rhode Island. And so I haven't seen you in 50, 60 years or something like that. So really wonderful to see you, Lynn. Thank you. But anyway, I would like to today, just to take this out. First of all, I can't believe all of you are here on a Friday afternoon. If I were doing this back at the medical school, there might be 3 of you here at this time. But I'm really honored, so thank you. And I'm particularly honored that you have a School of Nursing here at Providence College, because if anything we desperately need in our program, it's nursing. And I hope I'll show you today with a few of the things I'm showing you how critical nursing has been to us, really at the core of everything we do. So I'm gonna bore you a little bit with slides, but I'm gonna skip over some of them because I don't wanna bore you too much. So the first thing to know is exactly what Professor Delaney said. I didn't plan on doing this. So Lynn, when you were saying you didn't think I'd ever be a doctor, I didn't plan on this. I didn't get to medical school until I was about 30. Then I was sure I was going to become an oncologist because I loved cancer. And I got called into my chief of medicine's office when I was just almost finished with my 3 years of residency. And the city of Boston had gotten a grant to take care of homeless people. And the grant had come from a big foundation, the Robert Wood Johnson Foundation. And there was a requirement that the mayor had to meet with homeless people and so they could decide how they wanted to be served. And one of the things they wanted was a full-time doctor. So I got really literally conscripted. And so I agreed to do it for a year because I thought maybe after having been through college in the 60s where we were a little bit crazy, it was my time to give back. And so I did it for a year. He delayed my fellowship. But what I wasn't ready for, this is a picture of a later version of the homeless people who got together to tell us what we needed to do. And remember, I was a resident in the hospital completely, I knew nothing about homelessness, nothing about how to serve them. And they had gotten together with the mayor in all these feisty meetings in 1984, 85. And what they came up with was that our program had to be all about, and they got a legal document to sign this off, all about social justice and not about charity. And I had every friend that I could muster. We're going to volunteer and help us out. I had my friends going to dermatology. Lots of nurses were going to help us. But the homeless people said, no, that's not what we want. That smacks of charity. So much to my chagrin, because I believe in my heart and soul that volunteerism is what we should all be doing. That's not how they were seeing it at that time. They wanted the same kind of medical care and health care that we would all want. So that was the first, I think this is what they wrote together. They said this, and this, I won't show you, this will be, I think this is the last slide with words, okay, so don't worry about this. But they wanted continuity of care. What they had experienced all their lives was fragmentation and loss. They didn't have homes, they didn't have anything that was stable in their lives. The last thing they wanted was a whole revolving cast of characters that were going to take care of them. So they wanted full-time docs. And they wanted it to go from shelter and street, this is the first time I ever saw that, right through the hospitals, which is why in the introduction here, we've always had to have clinics in our main hospitals at Boston. Used to be Boston City, it's now Boston Medical Center, and at Mass General, which is the hospital I trained in. And they wanted us to be part of those hospitals because they thought if we weren't part of them, when they got sick, we would send them somewhere else. They wanted us to be involved in their care. Kind of interesting thing. And then we had to work in teams, and I won't belabor that, but was a hard thing for me to come to grips with, is they hated people like me. I was going to do this for a year, and their version of that was, oh man, you're going to come here, we're going to open up, you're going to get to know you, get to know us, we're going to come to trust you, and then at a year, you're just going to go do your job somewhere else, your career somewhere else. So they insisted we work in teams. So I've always had not my own panel of patients, if I could say that, but I've always worked with a nurse practitioner or a physician assistant, nurse and a psychiatrist and a social worker, so that we all share in the care of everybody. So if one of us leaves, each homeless person will still know the rest of the team. And then the last thing that I'll show you about, they also said you've got to come up with respite care. And when I'll show you later what that, I had no idea what that meant, by the way. There were no respite care facilities at the time, so it was a shot in the dark for us. But this is it. So just to let you know, this is Boston City, and this is Mass General, where we have the clinics. The thing that I didn't know very much about was shelters. So the job was we had to be based at the hospitals, but we had to go to wherever homeless people were, because their feeling was, you can't wait for us to come to you because we'll be too sick and life is too crazy for us to get there. So we had to go to them. And so the way our program evolved is we do the clinics in most of the shelters. This is Pine Street Inn. I don't know how many of you are from Boston or know Boston, but it's a shelter. At the time when I started, it was 800 people sleeping in this shelter. It's huge. And then there's a women's side of it and a men's side, but they separated the two. But when I got there, I thought, I just finished 4 years of medical school and 3 years of residency, and I thought I was pretty good, And I wanted the nurses to agree that I was, but it was a nurses' clinic that was running this clinic in the shelter for 15 years before I ever showed up. And don't you take this to heart if I say it, but when I walked in, I thought they were going to be thrilled to see me, and they were just annoyed. And they pointed out to me that, they'd been doing this for a long time without the help of doctors, thank you very much, and that if I would just listen up, they would teach me what to do. And I just finished a month running the ICU at Mass General. I'm at a shelter clinic 6 blocks down this road, and I'm going, what? I thought this was going to be really simple. Anyway, what they made me do was soak feet for 2 months. Okay, they took away my stethoscope. I couldn't do any of that stuff. And by the way, this is where Dean McGinnis, this is Barbara McGinnis who made me do this, whose name is spelled exactly the way yours is, which is the real way. But Barbara said, look, you've trained all wrong, you go fast. This is all about going slow. You're never going to get to know people unless you take time to share with them. You've got to have cups of coffee, and they're not going to do anything you say until they really believe you're there. So the way the nurses did it, which was incredibly powerful, is they invite people in and they just say, and first of all, they call them by their name very nicely. So it'll be Mr. Williams, can you come on in? Would you like to soak your feet? So I had to do that for 2 months as my apprenticeship. And I learned a lot of startling things. First thing was that, and you will all learn this when you're training, I was most of the time no further than a stethoscope's length away from somebody's very private space, very personal space. When you soak feet, you're down at the bottom of their feet, and the power structure is reversed, right? The other thing I hadn't realized was how powerful it is to call someone who's been wandering around all the time, never hearing their name said, at least not with any kind of dignity or care. The nurses would just have people melt when they would just treat them as normal people. Then I also learned, by the way, that people have tons and tons of stuff going on with feet. So I became actually a pretty good podiatrist during those 2 months. This was a man, I'll just tell you this quick story, that Barbara made me soak his feet because he was the only one that I had run into who actually remembered me as a doctor in the hospital. And I remembered him as a man who suffered from terrible schizophrenia, had all his life. It was a very paranoid version of it. And he used to be brought into the emergency room by EMS and people all the time, but he would sit there and never do anything we said. And so we had written in his chart that he was treatment resistant. And I remember soaking his feet for about a month, and at the end of the first month or so, he looked down at me. You have to remember now, I have nothing that says I'm a doctor at all. I'm just soaking feet. And he looks down and he said, "Hey, I thought you were supposed to be a doctor." And I didn't know what to say to that, but I lit up because the first person that acknowledged in a month that I was a doctor. And I said, "Yeah, you know, I am." And he goes, "What the hell are you doing soaking feet?" And I didn't have a good answer for him other than to say, "I do whatever the nurses tell me. That's what I'm here for." And he smiled because he had gotten to know the nurses and he did whatever the nurses said. So he and I were on the same wavelength with that. But about a week after that, actually a week after that picture was taken, he asked me if I could give him some medicine to help him sleep. Okay? And I was like stunned. And I said, well, you know, got to talk to him about what was going on. And I gave him some medicine. It worked a little bit, but not enough. So he came back and said, "Can you give me something more or different?" And within about a month of that, he was taking all of the medicines that we had spent 25 years at Mass General saying he was utterly resistant to take. So I can still remember Barbara McGinnis looking at me and saying, "See, that's what we're talking about." So it was really powerful to take time and earn people's trust. Then the other things that I'll share with you is how I thought I knew what people needed, you know, because I was trained in this kind of traditional way. And this man came in, I grew to love him, his name is Amerigo, and he came in one night, really, the way I got to know him is you could hear his voice. He had a laugh, it was like a cackle. So with 800 people in this wild, crazy place, you could hear his laugh above everybody else. And he just was magic with that. But he came in one night and he said, "Damn it, Doc, you gotta help me." And I said, "God, what's going on, Amerigo?" And I was waiting for people to come to me asking for that. And he said, "I can't swallow my vodka." And I hadn't, that was a new chief complaint for me. I don't know how often you'll hear that, but occasionally. But it's a bad sign. So I knew if he couldn't swallow his vodka, something must be blocking his esophagus or something. And he told me that he hadn't been able to eat for several months, but as long as he could get his vodka down, he felt it was okay. And one of the lessons I had to learn was people don't come to you until something's really broken. This is not about preventive care, at least not until you get to know them. It's about when something doesn't work, then they come to see you. So anyway, it turns out he had a huge cancer right in the middle of his esophagus. It was way past anything we could do. So I sat down with him and I said, "Look, this is, after we did the whole workup, there's not much we can do. You probably have a month to live at best." And I was doing my best oncology stuff. And he, looked at me. It was okay. We had to put in a tube so we could feed him because he couldn't get anything down his esophagus. And then I spent a weekend trying to get him into a nursing home, which had a nice end-of-life care unit. And it was in the area where he had grown up. So I did all the paperwork. This is before computers, by the way. Got him in and brought him there on a Monday. And I was so proud of myself that I was going to make sure he died with some sort of, with a bed and with people around him and some sort of dignity. And I came back, so I was sort of, slapping myself on the back. And I came back about a week later. I'd been coming in and out of the shelter each night. And I came back a week later, and I can hear his laugh, okay? And I'm thinking, this is not a good sign. He's out somewhere out there doing so. And I went over to see what was going on, and he looked at me and he said, "Hey, Doc, how you doing?" In the meantime, he's got his vodka, and he's pouring it into his feeding tube. And, I didn't know what I was going to, kill him. "What are you doing? We just got..." And then he read me the riot act. He said, "Look, Doc," he said, "thank you for putting me there, but I didn't know anybody. And everybody was looking out the window. Some were watching TV or just staring straight ahead." He said, "I felt just alone and utterly not where I wanted to be." And he said, "I've been at Pine Street here for 30 years. I want to die here with my friends around." So this picture I kind of cherish because it's one of the nurses at Pine Street. His name is Sheila, who, and the nurses got together, and we actually did the whole end-of-life care for him in the shelter, which with the other 800 people around. And this was Sheila when she was doing tube feeding. The lesson, though, was I didn't ever think to ask him what he wanted. And it was completely opposite of what I might have thought about. So we don't make that mistake anymore. Then I promise not to throw it. I don't know who is here is not medical, so there's not a whole lot of gross pictures. Okay, I had to pull those out. But this is another lesson in humility for me. So the staff at Pine Street, not even the nurses, the staff brought this man in to see me one night. They said, "Doc, you got to do something. We know this guy really well. He just doesn't look right." And I've since learned whenever, there's 800 people out there and somebody who knows them well says somebody doesn't look right, that you just turn the volume way up. But anyway, I looked at him. His name was Jack. He became a patient of ours for a long time. He was really angry that they had brought him in. He wanted to be outside with everybody else. And so I said, well, Jack, let me just do something quick so we can put the staff at ease. And he's got scabies. You can see, for those of you who don't know scabies, those are the things crawling. You can see the raised straight lines with scabies underneath. He has a skin cancer right in front of a basal cell carcinoma in front of his ear. And he's got some anatomical things if you haven't done anatomy yet, but he's got a pectus excavatum. And he said he was fine. He had no fever. His vital signs were normal. I did the best exam you could do in a noisy shelter. I couldn't find anything wrong. So I told the staff, I don't see anything acutely going on with him now. He admits he's smoking way too much, and he drinks every day. He has no interest in stopping that at this point. So I said, bring him back. If he's not any better in a couple of days, bring him back. And they dutifully brought him back. And we have an old X-ray machine at Pine Street. And for those of you who don't know, this is an X-ray done with an old cathode ray thing with tuberculosis like you only see in third world countries. And he's a man I had seen and examined and cleared 2 nights before. And so he became the first case of what turns out to be 60 cases of active pulmonary tuberculosis in the shelter. This is about a month and a half after I started. And it was resistant to the 2 main medicines that we give. It's INH and strep, which meant everybody needed 4 medications every day for 18 months to treat them. And if you didn't treat them, this was going to be spreading all over the place. And these are people, by the way, who can't stay in the shelter during the day. They go out and ride around Boston. So it was a real panicky time for us. And that's when I learned how really good the nurses were. Sorry, I'm Joe. It actually made, this was actually the first what they call MDR TB, for those of you who are interested in tuberculosis. And I could tell you stories about it's the first time I ever ran into Paul Farmer, if any of you know Paul Farmer. But he was a student then and came down, and he was never really a student. He was always like way ahead of all of us. But he came down and was fascinated by this multi-drug resistant tuberculosis. And this, by the way, is Barbara McGinnis on the left. She's a nurse who taught me everything, after whom we named our respite program. And Yoshiko is a nurse practitioner who was my partner in crime for 15 years before she went to Philadelphia and started a similar program. And this, for those of you who, most of you were not born back then, but these are X-rays that are not digitalized. Okay, these are X-rays we had to carry around and put up on screens to be able to see. And that was the command central for TB. But what we learned was from the nurses, basically. We learned that, I was overwhelmed. Here's 60 people. It's chaos. I'm just starting. We're already overwhelmed with a bunch of other things. How do you ever manage this? And we worked with the state and the city Department of Public Health, worked with the nurses, and then a lot of outreach help. And what we learned was that most homeless people, even though it looks like chaos when you step back, most people have a relatively ritualized everyday life. They go to about the same place. So we learned that with these 60 people, we could figure out their patterns. And what we also learned is that they don't come back. Once you got TB in the shelter, you never came back to the shelter because that's where you got sick. So you didn't come back there. So this was what we had to do. It was the first time I remember doing what we now call street medicine. So we would get on our bikes and go find people every afternoon. And this is Mark, who's a social worker, a caseworker that worked with Yoshiko and me on our team. And Ursula was a TB public health nurse. And they were out giving this man. This was actually a picture taken on the last day of the 18th month, celebrating that he'd finished. But just to show you how crazy it is, I spent a lot of time, by the way, I bartended for a very long time, Lynn, just so you know. But I had a friend who was a bartender at a bar just about a block down the street from Pine Street. And when I talked to him, we found out, this is days before HIPAA, but there were 7 of the men with tuberculosis who came in and had a drink there or more before they came into the shelter. And so we gave him the medicine, and he, for 18 months, would not pour their beer until they took their daily medicine. So he took care of all of those 7 men. And there was a man with a coffee clutch in South Boston who had 4 of the men who used to go get their coffee in the morning. He would make them take their medicine. By the way, if you go in to do any of this now, it's all illegal now because you can't give a bartender medication to give to somebody. But it worked. It's how we had to get this all done. And it taught me that we were useless as doctors unless we were part of a much bigger system. This is what the end point of that respite program, so what homeless people were mostly angry with us doctors about is when they come into the hospital, and they would be very sick, we would discharge them, as if they could go home with a family and visiting nurse and all that stuff, but they don't have any place to go. So they were really furious, and this was in the early days of the AIDS epidemic as well. Think about walking around the streets when you don't have a bathroom, when you've got terrible diarrhea from AIDS. It was awful. So they asked us to set up a place where people could come and be cared for after hospital. So it's like a post-hospital thing. And over time, I won't bore you, this is now 40 years later, right? But we now have it in a building that's right across from Boston Medical Center. We have 104 beds in there, which is essentially a hospital. You know, we have it's 24-hour care all the time. And things like this happen. We have a dermatologist whose name is Ernesto Gonzalez. Oh, am I doing something wrong here? Sorry. And Ernesto comes and does derm with the derm residents, so we can get our dermatology in. So we get all sorts of specialty care there. And it turns out you can't send people to specialty care because they never make it. Because I don't know if any of you have tried to make a dermatology appointment, but it'll be next January at 3 o'clock on a Tuesday, right? So everything has to be immediate in our world. If we don't have it immediately, you just don't get it. So this is Ernesto, and as you can see, it's our staff love him coming over because we can learn about dermatology. They also realize that we all have rashes, and you try to get them to look at it so you don't have to go to the dermatologist. And then the other thing that we're trying to, and I'll get more into this, but the rough sleepers, the people, by the way, I should have framed this. In Boston, we have about 3,000 shelter beds for adults, okay? And 95% of everybody who's homeless tonight in Boston will be in a shelter, and only about 5% will be outside. But it turns out that 5% is probably the most, they're the trickiest and probably have the highest burden of medical and psychiatric and substance use disorders of any population we know. And we call them the rough sleepers because they won't come, even though they're bed in the shelter, they won't come in. And those are complicated reasons why. Anyway, this is a man who was outside. We were trying like crazy to get him to come in. It was during the polar vortex several years ago. And he stayed out the whole time. And Dave Munson, who's our doctor right in the black coat there, is a doctor on the street team with me, finally convinced him to come on in. The price of bringing him in, though, remember it's freezing cold now, is we had to bring in his stuff. So one of the things we struggle with all the time is people have to carry everything they own with them. And they don't want to go into the hospital if you have to leave your stuff behind. So we're always worried about how do you get somebody in early enough to take care of something when it's still early rather than make them wait until they're so sick. So anyway, we got a flatbed truck to bring that, to go get his stuff so that we could store it in the basement of our building. It was highly controversial because lots of stuff was alive in there, so we had to deal with that. But he came in, and then when we took off his shoes, these were his feet. And I won't show you, I could show you lots of grip, but he had frostbite of both feet and eventually would lose both those feet from auto amputation. But we ended up keeping him with us for about a year. But just think he's outside walking with that. And where do you go? The hospital doesn't admit you for this stuff anymore. You're supposed to go home and we'll watch it at home. And I'm going to skip over the next picture if I can, because that's gross. The other thing was, so we can do lots of stuff like that in our respite program. The other thing we've had to do, which has been sort of at the core of what I wish I could do more of, is end-of-life care. Because like we saw in the very beginning, the mortality, the premature mortality rates among homeless people in Boston anyway, and most cities around the country, if you live in a shelter, you die at about 4 times the rate of someone your age that has a home in Boston. So it's a 4-fold increase in mortality. If you live on the street, it goes up to a 12 to 14 times that. So it's incredibly deadly to be out there, even though we don't really appreciate that because we only see it in snippets. But if you look long term, that's what happens. Anyway, these two men, Tommy, who's in his bed there, is dying. He's 84. He's dying of a neurological, very aggressive cancer. His roommate, who is 37 years old, half his age, has a lung cancer that's has metastatic to his brain. And they both have, several weeks to several months to live at best. So we took care of them in our McGinnis house, and they became kind of cool friends. And I could give you stories and stories, but just to tell you about, so Tommy, right there, worked for years, all his life, at the racetrack. We had a place, I don't know if any of you knew Suffolk Downs, but it was a thoroughbred racetrack in Boston where they raced all winter long. There were 1,500 stallions stabled there in the back barns, and then a whole bunch of people were hired, homeless and usually migrant workers, to take care of the barns and horses. And Tommy did that from the time he was 12 years old until now. And we went over there and was kind of blown away. This is Pat Day, who was the winningest jockey of all time. And it's all feels like majesty when you're out there. It's great. But then when you look, and this was one of the horse owners, but when you look behind the the, the stables where all the action goes on. This is Tommy when he was doing well. He was a genius with horses. This is one of the women there is Shirley, who owns a whole bunch of horses. And Tommy lived in one of the stables, along with a lot of other people. They just live and go in and sleep in the stable, often in the tack rooms, if any of you are there. And this is, you get a flavor for the stables. This is what we were showing some people around. So we got convinced to do a clinic out there, and our staff, we got a little, get an old van, staffed it up, and we started taking care of these folks, all of whom were working every day. They worked usually 18 hours a day. Many of them at that time were undocumented and being paid under the table. So they wouldn't come in for a clinic visit because they would lose their day's wages. And most of them are sending half of whatever they made back home to wherever they were from, either way down south or from Central and South America. And so we have that clinic, and our staff, we used to fight over who would get to go there, because these are the people that you would love to take care of. They were just amazing. Tommy among them. That's our nurse, Trish, I wanted to show you. So our nurses would do rounds while people are working, because they won't stop working. They keep moving as they go along. And for those of you who don't know, I was blown away by this, but when you have these high-strung, I don't know if there's any horse people here, but there's high-strung stallions that you're trying to, they're good races, but they get really jittery. You put a goat in with them, the goat keeps them calm. So goats are incredibly valuable on the racetrack. Anyway, Tommy, as he was dying, the only thing he wanted to do was go back and see the horses and see where he lived. So this is Byron. His thing. We would put him in the van once or twice a week and just let him go back to see, where he lived his life. And when you get there, I used to love it because when you got there, the horses would go crazy because this was the person that took care of them for so long. And this is about a week before he died. He was out there, and he was just all smiles. So something about him that really moved all of us. By the way, manure is actually saved on horse tracks like that, and it's put in these big trucks, and it's sent somewhere, then becomes fertilizer, and it's sold for a lot of money. So he said that when we died, he really wanted us to just throw him in the manure truck so that he could go fertilize something else in the world. It's kind of cool. And I'm going to skip over a little bit. So I could tell you lots of stories about working outside on there's a van that Pine Street has, funded by the Department of Public Health, which is actually really worth seeing sometime. But it goes out, started in 1985 when we noticed that people dying tended to be people not coming into the shelter. They were staying outside. So the van goes out every night of the year from 9 at night till 5 in the morning. And this is they're heroes in the story that I like to think about. It's these folks. They are out there. They're paid, so they're not volunteer. It's important that they're paid. And they, many of them have experienced homelessness. Many are in recovery, but they never judge anybody. They just go out there and take. And the van brings soup, sandwich, and blankets. I tried to make it a medical van back then, as did the nurses with me. But the homeless people that are on a board didn't want anything to do with doctors at 2 in the morning. They wanted sandwiches or blankets or something like that. So that's what we do. I've been riding on the van 2 nights a week since 1986. And it's how I've gotten to know most of the people who live out on the street. And it's like my spiritual home. And then we then decided we have a team, so we have a street team in our program. And we have, that's Dave again in the sweater, who's one of our doctors. And the man in the red is our psychiatrist who's full-time on the street with us. And then Romy next to me is our caseworker. And Suzanne in the middle is our nurse practitioner. And then Susie is our nurse on the thing. So that's our team. And it's our full-time job. That's who we take care of the people living on the street. And it's like the best job I've ever had because of them. We can do things like this. So this is a woman who's 82 years old, has terrible heart failure, hates to go to the hospital, and never goes until she can't breathe anymore. So, but what she does let us do is take care of at South Station. She stays at South Station, and we can do just about everything. The nurses, by the way, thank you for you guys. Nurses beat us up pretty routinely about why do we have to have people come to us, see us in the clinic, because we have all our stuff there and it's private. When in fact you can do about 80% of everything goes on in an exam room in a hospital or a clinic you could do at a park bench or a McDonald's table. So we've had to learn to accept that, and it turns out to be great. So this is managing her heart failure. She'd let us take her vital signs, we could weigh her, we could check her blood tests, bring her back to the hospital, do an exam, and get her, there's a CVS right next there so we can get all her medicine. And we worked together with the heart failure clinic at the hospital to make sure we did everything right. So that was about 10 years of taking care of her there before she actually got so debilitated she had to go to a nursing home. but it kept her out of the hospital. And it actually made us and her, I think, feel a lot better. And you know, it's fun. This is Katie is in the second from the left there is our newest psychiatrist on our team. She was just the chief resident at MGH and now has been with us for a couple of years. Becky's our nurse on the left, and then one of our other nurse practitioners, Katie, is with this man who lives back actually in that alleyway right there. And actually, it actually is fun. This is Jim Bonner again, our psychiatrist. He did most of his, he used to run one of the mental health centers here in Rhode Island. And then he came up, and when he started working on the street, he felt like he had a second life because he could do all these people that he used to think were treatment resistant. He could now sit at a McDonald's and over the course of a few months or something begin to treat them and do therapy and everything else at a McDonald's. We could do a lot of nursing stuff on the street, by the way, which is really, so we do flu shots for everybody. I learned a lesson, which I'll tell you in a minute. When COVID came, it was devastating. I'm sure it was devastating here, but if you live in a 500-bed shelter and COVID gets there, it gets really devastating. So we were, you know, it almost broke us in half. But we eventually ended up having to run a 500-bed hospital inside the Boston Convention Center for homeless people with COVID. And remember, what we all learned during COVID is if you want to isolate somebody or quarantine somebody and they don't have any money or any place to go, it becomes a real challenge. You have to feed people, you have to take care of them. So it's not like just go home and stay home. It's really complicated. So this turned out to be hugely valuable to us. But then here's the fascinating thing to me. So when the vaccines came out, I don't know what your experience with the vaccines were, but you know, lots of people were very skeptical of it. We had lots of debates about stuff, but they're pretty miraculous if you step back and look at them. And this is, you know, our nurse and Jen, who's our physician assistant. And when we finally had these vaccines after this devastating pandemic, we went out and started to try to give them to street people, thinking they would all say no. And it turned out we had, I would say, close to 100% of the people just said yes to a vaccine. And they said yes, I think, you know, because they had seen how devastating it had been for everybody around them, and they wanted to help out. But I think the more powerful thing was we realized that all that time we've spent getting to know people, like the nurses that told us in the beginning, when it comes time to give them a shot, it's the person they've known for a long time was giving them the shot, not someone in a clinic that they've never seen before. And they're much happier to say yes to that. So we were like kind of blown away. So we had, you know, overall in Boston, we had 84% of everybody living in the shelters got vaccinated. And on the street, it was closer to 100%. So that's a tribute, by the way, to the nurses, if I could say that. This is giving the vaccines at the park right at the hospital. This is Jen again giving vaccines. So you get the flavor that everybody kind of accepts as long as you would go to them. Now, I'm going to finish up with just a story of somebody here, because I can't really see the clock. Am I over time, by the way? I'm okay so far? You're allowed to stand up if you're bored, by the way. Having been through medical school, and you guys will do it, it can get very boring when you have these people up here doing this, so you're allowed to do that. But this is Michael, who became just one of the people we got really close to. And if I'm not saying this well, it's all about relationships, and the more you know people, the more you start to realize how incredibly courageous they are in leading life after being given nothing, you know, and having much of their lives taken away. Anyway, Michael I met the first night I was in the van, early in 1986, and he lived outside, and he was a character. He had real great street smarts, and as I got to know him more and more over time, you know, I started to realize he couldn't read or write. You know, he'd grown up on a cotton farm in the South, and then had been in an abusive situation, and he was taken out of his family thing and sent to some relatives in Boston where it was equally bad, and he was on the streets from the time he was 14. Never really had any schooling. But out on the street, he just, you know, he knew everybody and had great smarts. This is him. He used to stay at a Starbucks where he knew everybody coming in and out, would remember your children's names, everything. And that's how he got his money, by being great. And people actually loved him. It was on Beacon Hill. But I took this picture was he had come into a clinic. He frame shift now, so for 25 years he's out there. He comes in one day, and we had followed him for he has a lot of medical problems going on. He came in one day, and he had new lymph nodes above his clavicle, which is always a bad sign, by the way. If you see lymph nodes up here, then something bad is going on. And so it turns out it was the beginning of what turns out to be a pretty aggressive prostate cancer. So we brought him this is our McGinnis house. We brought him over there, and he taught all of us a lesson, but instead of being kind of annoyed by all this, the fact that he now had a bed, and this is our nurses with him, he had 3 meals, he was happy, okay? And we had him here so we could get him through his chemotherapy and his radiation. He didn't have surgery in this. And it was a long haul, so we stayed there and did it. When he had gotten through the first part, and it looked like he was going into remission, we moved him. We have another step-down thing now, believe it or not. So we have the acute respite, and then we have a relatively subacute respite in this building here. And he went there where he just charmed everybody. And this was I threw this picture in there because he loved animals. And we had these therapy dogs that used to come. And I now have a huge appreciation for therapy dogs when you have a bunch of people who are lonely and looking for things. And so he took care of the therapy dogs all the time. And then this is the fun part. So he was 60 years old now, never had a place of his own. So we found him a place, and this is him signing his lease. He's really, and his signature, by the way, is an X. Okay. And he's just happy. He's just happy. And it was kind of like for us, his cancer's in remission. We can finally get him off the street. But before we went to move him into his apartment, which turns out to be really nice, but he had to go to the animal shelter, and he got this cat so that he would have a cat in his apartment with him. He started to realize, the things people dream of that they hang on to. And so this is him, and he's just thrilled. His taste was kind of wild, but we got him, rugs and stuff. And what I'm not going to go into today, we've followed a lot of people who've been on the streets for a long time, and when they get housed, we have all these low-threshold housing programs, which is, I'd love to talk to you about it at some length over a lot of scotch. But what he would do is call us up, and we have one of the things that the homeless people made us do right in the beginning is we have to be on call to our patients. So when they call 24/7, someone they know has to answer, and we made that commitment. So he would call. I was frequently the one on call at night, but he would do these calls once he got housed. Like, okay, doc, he said, it's 9:30 and same old place in Jamaica Plain, closes at 10. I need a meatball sub, quick. And I was like, he's got cancer, and I'm worried about his cancer, but he's making me get food. But that's how we kept him in. We just do that stuff. And then he was incredibly appreciative. And then his cancer comes back with a rage. And this now, so he was in remission for almost 3 years, and it comes back. And then this is where what I would share with you before I stop here is that we learned that going out to the streets, going out to the shelters, if you really want to deliver the best of care, okay, then to a population that's really excluded from much, but has a high, what the leading cause of death among homeless people, adults in Boston is? Anybody got an idea? I'm giving you a hint here. It's cancer, okay, by far. So you don't think of homeless people dying of cancer. You think of them dying of cold or dying of assault or suicide or something. But cancer and heart disease are by far the leading causes of death. Drug overdoses are now, let me leave that alone, but we also have a lot of problems with that. Anyway, so staying near the hospital has turned out to be invaluable because what we needed when Michael was sick was just to be able to walk up to the cancer team and say, he's here, let's take care of him. And they were fabulous. And so we brought him in. We have a clinic there every day. I'm going to skip over this. We run a clinic every day at Mass General for homeless people. And this is it. I'm going to skip over that because it's another story. But here's Michael now as he goes in for chemotherapy. And so Becky, our nurse, had to make sure we picked him up and brought him there because he doesn't know how to do it on his own. And the chemo team is waiting for him. And I'll never forget, he insisted we had to get him breakfast first. So always French toast with lots of maple syrup. This is him before he's going into chemotherapy. Look at that smile. I would be devastated, right? And then I went up to see him on one of the first days when they get him all wired in. And he's in a bed with a flat screen TV, and there's a nurse helping him on either side doing the IVs and everything else. And they've given him food, he's got snacks. And he's sitting there, and he's just smiling. And he said to me, Doc, it just doesn't get any better than this. And I'm like heartbroken, because this is, we're worried to death that he's not going to live very long. Anyway, so it progresses, and he's now really sick, and he's now into the last weeks of his life. And we've been trying to get him to come to the hospital or come over to our respite program. But he won't come because of the cat. He won't leave the cat alone. So, God bless her. So Jen Nunes, who's our physician assistant, I was visiting him with her that day, and he's in agony. The cancer's all through his bones. He's really in pain. But Jen said, I'll take the cat and take care of her. Actually, to this stage and still has the cat. And then Michael was able to go to the hospital and do what he needed to do. So he went, and then the end of the story is that he went to the hospital. He's on the last week of his life. He is on all the medicines to make sure he's comfortable. And he calls up, I'm on my way to see him in the morning to make sure he's okay. And he calls and he says, you know, Doc, I think I need a Big Mac, but one of the ones without any lettuce, okay? So I don't know if you've tried to get a Big Mac without any lettuce, but it's hard. So I got it for him, thinking, you know, he's dying. I don't know what, you know, a Big Mac when you're dying doesn't make sense. And so I went into the room, and it's where I had a couple of other patients as well. And I said, you know, looked like he was an extremist. And I went, Michael, you know, I'm here. Do you really want this sandwich or not? And he bolts up. He sits up like this. This is the day before he dies, okay? He bolts up, and he is just so thrilled to get this Big Mac. He can't eat it. He can just smell it and then, you know, sort of lick it a little bit. But he taught this lesson of, you know, look at that joy. You know, he's about to die, but he's got what he's been looking for in front of him, and he wants to enjoy that moment. So it's something about all his life he was teaching us, you know, he was given nothing, but every time there was something that somebody might help him with, he would just so grateful and so joyful. Anyway, he died the next day after this. I think I'm going to stop right there and see if there's any questions. This is a picture I took that just shows you that we have a team, and you can do this as a team. And there's a lot of nurses in that picture, okay? There's a lot of homeless people. There's police, and there's volunteers, and there's a lot of medical students as well. So anyway, let me stop there and say thank you for letting me be here, and I'll do whatever.
Who's got the first question?
You really make students ask the first question? Oh my God, Ian.
Okay, so this is kind of like a two-part question, but so after reading the Rough Sleepers book, I noticed that like, especially one of the most influential people I read about was Tony, as I'm sure you know, and I loved that he like turned around and came back to help others. Did you see a lot of that where like once homeless people who were like housed or were like healed that only had like acute illnesses, did a lot of them like come back and help others?
For sure. You know, when a whole rabbit hole to go down that is really spectacular is the community of homeless people, because they don't have a community outside. People have usually abandoned them, and among themselves, they have really interesting relationships. So yeah, Tony was classic. When he was out on the street, his job was to take care of everybody. He's a big, tough guy who had spent years in prison, and nobody messed with him. So he's going to make sure nobody messed with others. And that was his reason for being. He's a very complicated guy, otherwise, as you know. But what I didn't tell you, you know that group of homeless people I showed you in that picture? So we still have what's called our Consumer Advisory Board, which is a bunch of homeless people who we pay to advise us on what we should be doing. And they are spectacular. And 5 of them are on our board of directors. So they literally hire and fire us. So we learn from them that they are, you know, they love having a voice in their own destiny, okay, which is what they don't have much of. So yes, the answer to your question, and thank you for asking it, is it's impressive. And with the vaccinations, it was a community response. It wasn't individual responses. So interesting. By the way, I have a confession. I've never read Rough Sleepers, so I know the stories only because I've read it, but it's a little too close to home to read, okay? Yeah. Although I love Tracy Kidder. It's not nothing to do with Tracy. He's fabulous.
Thank you.
That was only one part. Did you really have a
Oh,
part?
I mean, yeah, I did, but okay, I guess I'll ask then. So one thing that I've noticed, like as we've been learning about it in our nursing class, is like that it can be hard to like communicate with the homeless people because a lot of them don't want help or they don't trust you. So like when you're faced with that, is it really just about like gaining their trust and like trying to like improve and do what you can to help them? Because I know like sometimes we've seen and heard that they just don't want help and they think that like the healthcare system is not there to help them.
And absolutely, and one of the things that's going to be tough, it was tough for me in medical school and for you in nursing school, is you often don't get enough time to get to know people. You're at a rotation, then you go to something else. And I think for many of the people on the streets, it takes time, and I can't tell you how many of these people that I'm showing you now didn't talk to me for 2 years, you know, and then all of a sudden they talk. But once they know you're there to help, not to get in the way, which takes time, you know, then it gets much better. But it's a good point to remember that these are folks who I don't blame them for being angry. They don't want to talk to most of us because they haven't been treated very well by most of what we represent. But what I've been singularly impressed with is if you can talk to them, you can acknowledge them and just say hi and be patient. You know, you can't, if they don't want something, you just say, no problem, when you're ready, let me know. Then you'd be amazed at what happens. It's really pretty spectacular. So don't give up because they're rough. That's usually somebody frightened to death saying, stay away because it hurts too much in here.
Thank you so much.
So you mentioned cancer being a leading cause of death. Do you have, I guess, the facilities and the personnel to do gynecologic cancer screenings and even just routine care?
Oh, yeah. No, we have, it's a great question because part of what we had to get over was you think of it initially as going out and doing first aid and episodic care. But in fact, if you're really going to do good care, as you'll learn with all this, you really want to do continuity of care with preventive care as well as acute care. So yeah, no, we have like, I guess we have 35 doctors in our program now. Several are, and we do all the regular screening. What I will tell you was interesting is on the street, for example, when I first started talking to the women on the street, there's about 3 men to every woman on the street. That's the ratio. I couldn't find a single woman who had a pap smear in her memory, and almost no one who had a mammogram. And it turns out, you have to get mammograms scheduled, and they never did it. And pap smear is a really invasive thing. And what we learned over time was if we could do, like the nurse practitioner and the physician assistant on our team, as they got to know women, the women would always say yes and do it. But usually had to do it when they were admitted to the hospital for pneumonia. You can say, can I sneak in a pap smear or get you a mammogram? So we had to learn how to work around the edges. But now, we have the same rates of screening of people on the street as we do with our people in the fix-up clinics. But that's all about relationships. It's another great example of that.
I know you had mentioned that you were offered a fellowship post-residency, and then you were only going to do a year working with the homeless. So obviously building trust with the homeless is the most important part of care. When did you make that decision that you weren't going to go pursue your fellowship and you were going to stay working with the homeless? And did your patients, were they aware of?
That is a great question, and I think a lot on that. By the way, my father's dead now, but right up until he died about 5 years ago, he kept wondering when I was going to get a job. Okay, so there's a certain part of this that everybody, they still thought I was volunteering something. But you know what happened is I delayed my chief of medicine delayed my fellowship for a year, but it turned out to be the year when we had this TB outbreak and the first cases of AIDS hit the homeless spot. And we had, by the end of that year, we had literally hundreds of our patients had AIDS and were dying. We had no treatment. They were all dying slowly with these awful, and I was in the middle of that. So I asked him if I could stay I said, we're just getting started. Can you delay it one more year? So that actually gave me a chance to get to know people well enough. By the time that was over, I was hooked. But it was not what I intended to do, just I got hooked. Okay. So my lesson to you is stay wide open to what's going to happen to you, because it's, you never know. And you will almost always run into the thing that clicks for you. For me, it unfortunately waited till a very long time in my life, but it happened. Thank you for that question. Yeah.
When you, because obviously you built a lot of connections with these patients, like Michael, and then in the book, Rough Sleepers, Tony, how did you deal with your mindset in managing the separation between if they were to leave for months on end, worrying about them and getting your mind all involved about where they were and you didn't know what state they were in? How'd you deal with that?
Not always very well. Okay, so the question, everybody heard the question, here's the microphone. But so one of the things we're passionate about is staying close to people. We pursue them. So I think of my life, I get to see people at nighttime out in the van. I'll see them there. If they go to the hospital, I take care of them in the hospital. Or they can come to our McGinnis, we'll take care of them there. Or when they get housed, we'll go to see them at home. So it's like we pursue them. And so some of our patients will say, we just get out of here, it's leave me alone. But I think what mostly happens is we worry about death. And so people could die all the time. They die somewhere, and no one knows who they are. They're in a morgue somewhere, and nobody claims them. And we don't know where they are. And that, we always have that fear. It lingers. If you haven't seen somebody for a couple months or a couple weeks, Did they die? You know, and that we struggle with all the time. And that's when it's nice to be in a team because you can share that. The other thing that happens is often they'll get arrested and they'll be in jail somewhere, and no one tells you they're in jail. So it's almost like a relief when we hear they're in jail because we know at least they're alive. But it haunts everybody who does this job. It's just tough. The good side is that for most of the people, we know where they are all the time, which is nice. But sometimes we lose them. Yes?
Hey, Dr. O'Connell.
Hi.
Thank you very much for speaking. I was just curious, so you're Irish Catholic, you went to Notre Dame, studied theology at Cambridge, and then you dedicated your life to serving the homeless. I was wondering how much of your work is spiritually or religiously motivated?
Can I go to the next question? No, I'm kidding. I think about that a lot, to be honest with you, because, you know, I grew up in Newport. Parish was the center of our lives. Newport, for those of you who are not from Newport, is largely an Irish Catholic enclave. You know, and I don't think I've ever been able to escape. You know, I've had lots of issues with the formal church, as you can imagine, especially in my generation. You know, and then we had the 60s where we all revolted against that. But somehow you keep coming back to there are some roots that just, you know, I think we get beaten up by our parents. Like, our job is to take care of others. That's what you really should be doing. And how do you find ways to do that? So I don't think that's particularly Irish. I think my constant guilt is an Irish part. But I think growing up in a world where it's about other people, which is what I think you are doing here at Providence College, and I'd hang on to that, because that's, you know, I can't believe it, I'm like 76 years old now. How did I get so old so fast? But when you look back, it's what you've given away that makes you feel good, at least for me. And I would say keep that in mind. It's really, you've got to learn how to be the best you can, but you want to be giving that away. And I think I'm preaching to the choir here, because you wouldn't be at Providence College if you didn't believe that. And you wouldn't be in nursing if you didn't believe that. Okay, but thank you for that question. Yeah.
Hey, appreciate you coming to speak with us. My name's Elijah. I'm a sophomore here. And obviously you're doing some great work. I was wondering, what are some of the toughest parts of like helping run an organization like this? You know, it could be the people you're serving, trouble getting nurses, or like funding. Is there any big problems and like any solutions you see to that?
No, that's a massive question, Elijah, there are huge problems trying to run programs like this. We have 700 people in our program now, okay? It's about an $82 million a year operation. And there's a big problem every day, and it always surprises me. So being able to run a program that protects the clinicians to do what they need to do is the challenge for us. And most of our money comes from Medicare and Medicaid, so we have to do all this stuff that Medicaid requires of us. And then we have to raise money on the side, because Medicaid doesn't let you take all this time with people. We can sustain a lot of ours, but we need philanthropy to be able to take time. So we have to raise a lot of money, is what we end up doing. And over the years, I mean, we started very small. We have the advantage of started small with a grant. We didn't have to do anything except just go take care of people. And then to sustain ourselves, we've had to change with time. But I would say anyone who wants to run a not-for-profit, especially really mission-driven, which most not-for-profits are, then you weigh that thing between making sure you stay close to the mission, but how do you sustain it with enough money to protect the people that are working there? And that is a daily challenge that if you're going to do that, it's the best, but boy, it takes a lot. And that's where I would say get mentor. If you're going to do this, have mentor. Go talk to people that have done it and let them know. But is that fair enough? We could talk for hours about this, but that's sort of the headline.
Might be similar to Elijah's question, kind of. But as someone who wants to be in health equity after their 4 years at Providence College, and who's not going to be going to medical school and getting those opportunities, kind of like that, do you have any advice for someone to kind of get into that field in a way, in a way where they wouldn't have to be like a medical personnel?
Yeah, in many ways, getting it health equity requires often not the doctors and nurses, but people that have a better vision of that. So there's all sorts of ways to get into health equity, you know, through policy. You know, I don't know what you plan on doing, but you know, for example, there are a lot of doctors I know who don't doctor anymore. They just do health policy and equity issues, you know. And when I think of who are the really good ones, people that have done politics and policy are really good when it comes to equity, and we need them. people with good business minds are really good. So I would argue you could train in almost anything. The key is just get good at whatever it is you're doing, and then put on an equity lens and come back, and you will be invaluable in that. You don't have to be a doctor or a nurse or a social worker by any means. Yes, sorry.
Thank you so much for your presentation this afternoon, really powerful, and thank you just in general for the work that you do. I was struck by just a short comment you made along the way about the bartenders who are no longer allowed to dispense medications. I think one of the things that you are offering us today is a picture of care for people that is very local and very focused on the individual. And when you know people in this way, you don't need to think so much about the rules. Instead, you're thinking about what each particular person needs. So I was wondering if you could say a little bit more about the changes that now prevent the kinds of good behavior, good actions that those bartenders did in the past, and where we find ourselves now, given the general perspective that you're bringing us.
Ooh, that's a probing, really good question, because if I were to think about it, so in the beginning when we were starting up, we had been given a grant, and as Barbara McGinnis used to say, the only way to do this work is to be under the radar. You have to be, she used to call it live in blessed obscurity, because as long as nobody knows what you're doing, nobody cares. So we never told anybody about the bartender. You know, it wasn't like we announced it. I only told it like 15 years later. But if we tried to do it now and announce it, they would not let you do it. So what I think we learned is that if you try to individualize what you're doing, you have to be humble and stay quiet and figure out what works. As we got more and more institutionalized, because we have to live by the rules of Medicaid, for example. So we had a grant, it was the name of the deal with the grant was to go out and take care of people living under bridges and shelters. And it turns out when we became then Medicaid funded, which was how we had to sustain ourselves, then you had to only deliver care in a licensed medical clinic. And what's under a bridge isn't licensed. So they would say you can't do that. So we've had to work over all these years to make sure, and there is now a rule that Medicaid says you can see and bill for people under a bridge. It doesn't have to be in a fixed site medical clinic. But that took years and years. And what I've learned is as we see, as anyone sees holes where let me step back. So taking care of homeless people, like many vulnerable or excluded populations, when you go out to try to take care of them, they show you the weaknesses in our mainstream system really quickly. Like respite care. Who would have ever thought you need respite care? And now I can't imagine life without it. But, so as they show you those weaknesses, trying to address it for the individuals usually means you have to break a rule, because the reason they're out there is a rule that means you can't go out there. So we've had to learn how to sort of work that around, and then over time try to convince people to look at it differently. And there is a general rule that says whenever you create a program to reach out because the system is blocking them, if you try to reach out to take care of them and then you start to grow, then they will try to bring you into the mainstream system with all the rules. So then you have to set up a whole nother program to go do what you used to do. So I think that's a given, and we just always try to work around the edges on that. But it is a great, that's a PhD thesis someone should be doing, because it really is the story of our healthcare lives here. Yes?
Hi, thank you for speaking today. I had a question about you mentioning the care you give not being preventative and mainly being urgent care, about the homeless coming to you when they need it and not like preventatively. Have you done preventative work other than vaccinations, or how do you find yourself helping people in preventative care instead of just urgent care?
It's a great question, and that's been a long journey doing that. So I'll give you an example. So when we started, everybody I took care of, literally hundreds of who had AIDS died. And it was 11 years later we finally got a medication, right, that worked. And then the question was, how do you make sure people take these very expensive, hard-to-do medications and stay alive? And that, I don't know if you call that preventive, it's like secondary prevention. But what we've learned, like we have a team now, that, with a couple of really amazing doctors and nurses. The nurses call themselves NAGs, it stands for nursing something or other. But we have probably 700 people with AIDS that we still take care of, and 95% of them are on medication with virally suppressive. So you can do it. Now, wouldn't it be nice if they had a home? They don't have a home. The real issue is how do you get people housing? But we've had to come to grips with the fact that we can do a lot of preventive health care, but being able to get somebody into a house would really be the best preventive care we could possibly do. It isn't usually good, it's not necessarily good care, but it's good preventive care. Other things, like we manage tons of people with diabetes. We used to, insulin used to we used to have to refrigerate insulin, and you can't do that very easily in the summertime when they're outside. So we've had to come up with all sorts of creative ways to take care of people. But we've got a ton of people that are doing well on insulin without access to good food. Hypertension, we've managed that. We have a lot of heart disease, we have to manage that. So I think we've evolved into being just what you would do in a regular, with a doctor's office or with a medical home place. We just had to learn how to do it around the edges. But we do concept because we figure we're failing. If we don't do that to people once we've engaged them, then you're not doing good care. Great question, though. We always need to do it better. I mean, we're maniacs about quality improvement. But how do you get more and more, and what's the secret?
Hi. So you mentioned people experiencing homelessness can be very substance motivated. So obviously you have to do whatever it takes to get people to accept care. But how, moving forward, do you think we can most effectively prevent substance abuse amongst a community that tends to be very dependent?
We do a terrible job at preventing substance use. Usually what we're doing is trying to take care of someone who has a substance use disorder, and then we're trying to figure out how do we offer them medications and a way out. But we're terrible. Once you're homeless, two things happen. One, many people become homeless because they've lost everything, because they became, for whatever reason, addicted to something. And then if you're outside on the street trying to live in the wintertime, sometimes it's your substances that get you through the night and the day, and then you become addicted because of your circumstances. So we've done a terrible job at being able to prevent that. But we have, we do all the rest. We have tons and tons, hundreds of people on, medications like Suboxone and methadone and all the things you can do to try to help them. What we're missing is what the larger system is missing, which is long-term recovery programs, places where people can go after you get them sober for a few days. Where can they go? And so we struggle with that. About 70% of the people who live on the streets have a very active and complicated substance use disorder. So we're struggling with that a lot. Yes, I'm sorry.
Okay, just wondering, how do children fit into your program or your way of working with, they're homeless children?
We have a whole part of our program. I didn't get into this. I probably should have, because I'm an internist. But one whole part of our program is dedicated to family homelessness, and it's very different than individual homelessness. So I'll give you an example that in Massachusetts, where we're not. I have to remember we're not in Massachusetts, right? This is Rhode Island. In Massachusetts, we have a right to shelter for families. So if you're a homeless family in Boston, the only other place in the country that has a right to shelter is New York City, which has a right to shelter for individuals and families. Massachusetts, not individuals, but it's families. So we don't see families on the street because the state is obligated to get them somewhere. There's a crunch going on right now because we've just had 7,000 families come in from across the border, sent by different places, most of whom are Haitian families that were in Chile, and then they went up to Mexico, and now they're in here, or Venezuelan families. And where the state system for making sure they have a place for them to live is bursting at the seams. So that said, though, most of what we've had to do, our team does a lot of well child care, a lot of caring for families, but most of the families, unlike the adults, will be housed within 3 months to a year. The adults, there are some people I'm caring for that have been 35 years on the street, 40 years on the street. So it's slightly different because of the state rules. And here's another thing just to share with you. If I were homeless tonight, I could go down to Pine Street Inn, say any name I want. There's a bed. I could take a bed. But if I'm a family and I'm homeless, you have to go to the state, where the state office, and they vet you to see if you're really truly homeless. Is there a better place you could be, like staying with your family? And then they assign you a place to be. So it's very regulated. It's a front gate, and it's very That doesn't mean they don't have huge problems with the families, but that's how it's done. So we end up doing care for families, not in the streets, but in the motels and hotels where they're assigned, and the family shelters. Is that fair enough? It's another, I should have talked about that, but that's so complicated. Yeah. And we've had to work with the schools. Think of the schools, you know, you've got a normal school and all of a sudden there's, you know, right now where there'll be 100 families move into your neighborhood and those kids are all now in your school system. And they've all come from some terrible journey of trauma and everything else. So to teach everybody, it's really difficult. So, yes, sorry.
Hi, first of all, thank you so much for sharing your story and the stories of so many others. It was very inspiring to listen to. I think something that I was reminded of during this presentation is the fact that, you know, houselessness and the medical issues associated with that is certainly a systemic issue, and a lot of it comes down to policy. So how do you stay motivated to continue doing this work when you know that there are policies in place that are trying to make it difficult for you to do that work, and most notably, policies that are allowing people to remain unhoused?
That is a great question, and I mean, that's a question I think we all are going to ask as we do our lives, right? I'm going to answer it by going back to McGinnis, who is, Barbara McGinnis, by the way, was just a real character. She was a good friend of Dorothy Day's, you know, so she was kind of Catholic worker-like. But she was a third-order Franciscan as well. She always wore sandals, but never talked religion of any kind. I remember walking in one night, you know, and it's overwhelming when you first start to go into a shelter, right, and what's going on. And somebody was there and asking Barbara, who was the person who knew everything, you know, what's the answer here? What's the solution to all this, which is what we ask all the time. And she would turn around and just say, God, don't bother me. I'm too busy right now. And then she'd get back to work. And I think there's a certain wisdom in that I didn't pick up then, is that the problem of homelessness, and I would urge you all to think about this, is a societal problem. You know, we have homeless people, and clearly we don't have enough affordable housing, so we need that. But I can give you lots of examples of when we get some of these folks into housing, that's not enough. You need a huge amount of, they live through hell, they need a lot of support, and we don't give them that support. But that's one thing, so we need housing. But then if I don't know if you heard me say, so 25% of the people who live on the streets of Boston can't read or write. So that problem, if you say, what's a social determinant or driver of that health? That's a school system 40 years ago, or a family foster care 40 years ago. So most of what's driving homelessness is we got to fix our schools, we got to fix the jails and the correction system. You know, the weaknesses in those sectors are just feeding people into this end point of homelessness, but not immediately. It's 10 and 20 and 30 years ago. And most of us are stuck with this small time frame of what can I do in the next 2 years to, and I don't think it's going to work. That said, don't get that confused with there's like tonight, you know, you could put your hand on 700,000 or 800,000 homeless people in America, right? And it's going to take years to get them housed, right? And who takes care of them while they're going through that? And I think of it as a population that's screaming for us to care for them. But we're not caring them for because we think we're going to solve the problem. I'm not going to solve that. I'm a doctor and I will take care of people and I will pray that we get the place solved, but only when it's a national desire. So that's how we escape, okay? Because what motivates us is getting to know people. I'd love to get them out of homelessness, but I probably can't, but I can take really good care of them, you know? And we can make sure we surround them with a lot of love and care and, oh, the cat. Oh, the one who's separate, he actually did, actually, Jen Nunes, who's our physician assistant on our team, still has that cat. He died about a year ago. She still has a cat at home. But when she took the cat home, he agreed to go to the hospital so that he knew the cat was being taken care of. I'm sorry? Oh, I'm sorry.
Hi, thank you so much for coming. I'm aware that your organization is located in the Boston region, but have you explored partnerships with organizations that have like similar objectives in Rhode Island? Just like, given how close the two states are?
That is a great question. And over the years, like we used to hang out a lot with the folks at Crossroads. Are they still going? You know what? We're also, a lesson of homelessness, okay, I want to share with you is, I've worked a lot in LA and Skid Row, and it's a completely different problem than homelessness in Boston. And I'm guessing Providence is going to be yet more different. And you're subject to all your local, whatever the locals. So no, we haven't done a lot. We do a lot of sharing at like conferences, but we don't have like a shared care thing. We, you know, we've gone in, you know, I know a lot of the people, at least in the old days, I knew a lot of the people at Crossroads. We used to spend time with them, but we don't do much sharing. And there's very little sharing done across cities. It's usually inside a city. How do you get everybody who's involved with caring for homelessness to work together? That's usually the thing. But it's a great question because you would think we should be doing that, but we don't.
Please give,
That when you finish nursing, will you do that? I think you should do that. Okay.
please give a warm round of applause for Dr. O'Connell.
Thank you, Ian. Okay, I'm done.
And don't forget to join us down the hall.
Thank you. And I just want to say it's so good to be in Rhode Island, you guys. So if you ever come down to Newport, please come and say hi to us, okay?